Good afternoon. My name is Joan Reed. I am Dean for Diversity and Community Partnership at Harvard Medical School, and I want to welcome you to our Equity and Social Justice webinar. Today, we are joined by more than 650 individuals, and we're here to talk about Native American health and COVID-19. This webinar is sponsored by the Harvard Medical School Office for Diversity, Inclusion, and Community Partnership. And the mission of DICP, our office, is to advance diversity and inclusion in health, biomedical, behavioral, and STEM fields in ways that build individual and institutional capacity to achieve excellence, foster innovation, and ensure equity in health locally, nationally, and globally. Our efforts support the career development of junior faculty, trainees, and students, identify and train leaders in academic medicine, some of whom you're going to hear from today, and provide programs that address crucial pipeline issues. This equity and social justice initiative and series has 4 areas of focus. 1, history and context. 2, culture and environment. 3, health disparities. And 4, leadership and skill development. And today's session relates to COVID-19 and its impact on vulnerable populations, particularly Native American populations. I'm going to soon turn to our moderator for the program, but I'm so pleased to be able to say today that for our panelists, 4 of them, 3 of our panelists and our moderator, all participated in our Commonwealth Fellowship Program in Minority Health Policy, a leadership development program. Lyle Ignace, Ann Newland, Don Warne, and Alden Landry. And our other panelist, Patrick Linson, is someone who, as a Harvard Medical student, really taught me a lot and also worked with our office in designing programs that would specifically target the Native American population. For me, it is such a pleasure to see these individuals who've moved into strong leadership positions and are making a difference in our country. I'm going to turn to Dr. Landry, who's an emergency medicine physician at Beth Israel Deaconess Medical Center. He's the founder of Motivating Pathways, and an assistant professor at Harvard Medical School, but importantly for our Office of Diversity, Inclusion, and Community Partnership, he's the assistant dean for this office and leader for this series. Dr. Landry.
Thank you, Dr. Reed, for that introduction. I just want to make sure that we are all here today to talk about a very important topic that has been bubbling up in the background, but not necessarily gaining the same attention as other health disparities that we've seen when it comes to COVID-19. And so with that, we assembled an amazing group of presenters who are going to bring their boots on the ground experience as well as their leadership experience in this space and have a conversation with us about COVID-19 and how it's impacting our Native American communities. Next slide. This is just a quick overview of how the day is going to flow. You've already heard from Dr. Reed. I'm going to introduce our panelists. They're going to answer a few questions that we have set for them. And then after that, we're going to open it up to a Q&A session. Please feel free to use the Q&A option as part of the Zoom webinar so we can take as many questions from our audience and engage you all and try and answer any questions that you may have related to COVID-19 and Native American health. As for a couple other housekeeping notes, all of your lines are muted and please use the questions tab. We will make sure that the webinars are recorded and available on our DICP website at a later time. And also importantly, there's going to be a poll at the end where we want to engage those of you who are participating in this discussion to try and identify if there are any other topics that we in the Office for Diversity, Inclusion, and Community Partnership can help bring to the forefront as part of our discussions around equity and social justice. So please be sure to stick around for that at the end. Also, one additional housekeeping item is that we do have closed caption available if you would like to access that, as was indicated on our initial slide. Next slide. So I just want to go over a quick overview of what is happening with our Native American communities. And please understand that the reason why we have these 4 individuals here is because they are the experts in this space and can really open up our eyes to what's happening with their communities and the patients that they're caring for. So there's 574 federally recognized Native American tribes. And while the numbers may vary by tribe and by state, it is clear that our Native American communities are some of the hardest that are being hit by COVID-19. Navajo Nation is reporting more COVID-related deaths per capita than all but 2 states in the United States. The goal of this discussion is to talk about the why. Why is it that we are seeing these disparities, and what can be done to improve the health of our Native American communities, with the goal of thinking about this in real time and also what can be done in the future. We're going to talk about what are the needs. We're going to talk about what are the pre-existing health inequities that are being exacerbated by COVID-19. And then most importantly, we're going to talk about what can be done to address these inequities. And so with that, I would like to introduce our speakers. So our first speaker is going to be Dr. Ann Newland, who is the Chief Executive Officer for North Country Healthcare, a federally qualified community health center with 13 clinics across northern Arizona. Prior to working with North Country, Dr. Newland worked for the Indian Health Services at Kayenta, Arizona for 8 years. She is trained in internal medicine and pediatrics at the University of Tennessee in Memphis, and later completed her master's in public health degree at Harvard School of Public Health. And as Dr. Reed mentioned, she participated in the Commonwealth Fund Fellowship in Minority Health Policy. We'll also hear from Dr. Lyle Ignace, who is a member of the Coeur d'Alene tribe in northern Idaho and Chief Executive Officer of the Gerald L. Ignace Indian Health Center in Milwaukee, Wisconsin. Dr. Ignace received his master's in public health also at Harvard School of Public Health and completed the Commonwealth Fund Fellowship in Minority Health Policy. He was trained in internal medicine out of the Medical College of Wisconsin and earned his medical degree at the University of Minnesota School of Medicine. We will also hear from Dr. Patrick Linson. He is a Navajo and Pueblo physician that was born and raised in Santa Fe, New Mexico. He works as a radiation oncologist for Scripps MD Anderson Cancer Center in San Diego. He attended Harvard Medical School and Harvard School of Public Health. He co-created Harvard Medical School's 4-Direction Summer Research Program, a program designed for Native American undergraduate students pursuing a degree in medicine or biomedical research. And finally, we'll hear from Dr. Don Warne, who is the Associate Dean for Diversity, Equity, and Inclusion, as well as the Director of the Indians into Medicine and Masters of Public Health Programs, and Professor of Family and Community Medicine at the School of Medicine and Health Sciences at the University of North Dakota. Dr. Warne is a member of the Oglala Lakota tribe from Pine Ridge, South Dakota. He received his MD from Stanford University and his MPH training from Harvard School of Public Health, where he also completed the Commonwealth Fund Fellowship in Minority Health Policy. And so with that, I would like to turn it to our first speaker, Dr. Newland. And Ann, I just want to open up with a question for you. You're based in Arizona. Your catchment area for your clinics is adjacent to Navajo Nation. Can you talk about what's been happening in Navajo Nation when it comes to COVID-19?
Yeah, thanks so much for that, Alden. North Country's clinics abut tribal areas, and then we also have some programs in cooperation with Navajo Nation. We run the Ryan White Part B program that serves both the Hopi Nation and Navajo Nation. And we also do RECEPT screenings, radiation screenings. We have a number of staff who live in communities like Tuba City, Moenkopi, and Loop. So the impact of the explosion of cases on the Navajo Nation has been felt very personally by folks here, the impacts of the curfews and the deaths of people from this disease. If we could turn to the first slide, I'd like to ground us in, and actually the second slide, I'll ground us in a place. So for folks who may not be familiar with the Navajo Nation, this is a map of it, and it's divided into service units. These are the medical units that deliver healthcare, one of the ways that healthcare is delivered on the reservation. And Navajo Nation is over 27,000 square miles. So it is predominantly in Arizona, but also is in New Mexico, and there's a little strip into Utah as well. So multiple states, very tremendous distances, and people live in very dispersed ways. Just to give a little context, Navajo Nation is about the size of West Virginia, if that gives you another point of reference. And Kayenta is the area that I know best. That's where I lived and worked for 8 years, but I've lived and worked in Northern Arizona for 15 years and have a lot of professional and personal connections across the entire region. So you may not be able to see the tiny town of Kayenta, but if you look at the map and find Kayenta and then follow Highway 160 to the northeast toward a town called Denahotso, you'll cross Navajo Highway 59. And if you take Highway 59 south, you'll run into a small community called Chilchimbito. So there's only about 23 miles between Kayenta and Denahotso, and Chilchimbito is about the same distance. And that's the road that you take to get to Chinle. So just to give a picture of the type of health facilities in this area, Kayenta operates a clinic that would see 20,000 patient encounters a year, and an emergency department. Chilchimbito has a little 2-room clinic. It actually used to be a chicken coop long ago and far away. But a few years ago, they got a grant to put in a modular building. But this is a small clinic, just a couple of exam rooms. Same with Denahotso. Denahotso just has a couple of exam rooms. So it's you can provide good care there, but the resources are extraordinarily limited. And I highlight Chilchimbito because that's the site where people think that COVID-19 really began to explode on the Navajo Nation. So back on March 7th, that's a Saturday, and that's before there were any significant restrictions on movement or travel in the state of Arizona. There was a large church rally held in Chilchimbito. There were dozens of people from communities like Cameron, Kaibato, Lichi, Tonalea, and Navajo Mountain. And all these communities are in what we would call the Western Agency. So including the Kayenta service unit and Tuba City service units in particular. And if we go to the next slide, you can see that this is a map of Navajo Nation. This is from the website of Navajo Nation, and it's broken into the service units, and it shows you the number of cases in each of these service units as of yesterday's update, or 2 days ago update. I looked at it today, and the numbers are even worse. So you can see that there's hot spots in areas in the Kayenta service unit and in the Chinle service unit in particular, but the entire reservation is heavily affected. If we could go to the next slide. Thank you. This shows the number of cases across the state of Arizona based on numbers of yesterday. And the largest red block you see is Maricopa County. It's not surprising that they have the largest number of cases because it's the biggest city in Arizona. Phoenix is the 5th largest city in the United States. So by population, it makes sense that you might see a large number of cases there. But when you look at the rate per people living in a given community, Coconino County, that large kind of triangular county in the center, Navajo County just to the right with 682 cases as of yesterday, and Apache County with 392 cases as of yesterday, you can see how many communities in the tribal areas are affected. Coconino County is where I live and where Flagstaff is located. And in Flagstaff, there have been about 50 cases identified of COVID-19. And in the community of Williams and some of the surrounding areas, including Page, it's another 50. The rest of those numbers are all cases from tribal areas. And I tried to break that down on the right-hand side so that you can see for Coconino County, at least as of yesterday, over 300 of the cases attributed in the county were for tribal areas, In Navajo County, it was close to 600. And Apache County didn't have the data. And I would highlight that both Navajo County and Apache County are incredibly poor, under-resourced counties in terms of their health departments. Coconino County, as many counties, is also under-resourced, but it's better resourced than some of these other rural counties. So I hope that just helps paint a picture of the problem.
Thank you for that. And so you mentioned about being under-resourced, and I would love to hear your thoughts about what you have heard and what you have seen, and how the local health facilities have been able to respond to COVID-19. Are the local health facilities, are they also as under-resourced as the rest of the community?
You know, there's variable degrees of resource, and it's all a matter of comparison. So having lived and worked in this area for a long time, I know what tremendous and heroic work the providers at hospitals like Chinle, Tuba City, and Shiprock do on a daily basis for patients. But these are small rural hospitals. Tuba City has approximately 17 ventilated beds right now. They've ramped up to try to accommodate the needs. But by the third week of March, Tuba City was intubating 2 to 5 patients a day. That's a lot for a small rural community when you don't have a large census. And that meant that they had to transport out at least 3 patients a day. And when you're transporting an intubated COVID-19 patient, that means you're sending them by flight. You know, when you're limited in terms of your ICU beds, you also have to think about what sort of resources do you need in place to staff those beds. You've got to have nursing staff. You've got to have physicians. And I think COVID-19 is a condition that's challenged all of us to learn how to manage. So how do you expand that expertise you can tap into when you are a small rural facility? I know last month, over half the ER nurses in Tuba City were positive for COVID-19. So there's really significant impacts in the medical community. But we also have to think about what's the impact on the public health nurses, because on the reservation, they're the backbone to communicating with families and vulnerable individuals who may or may not be able to easily access medical care. When I talked about the distance between, say, Kayenta and Chinle or Kayenta and Denahotso, there's many people who live off non-paved roads, so maybe a graded dirt road, and it can be harder and harder to get to the type of care that they need. You know, one of my longtime patients lives outside Denahotso with a couple of her daughters. She's elderly and oxygen dependent, and she has an oxygen concentrator at home. But one of the challenges her daughter faced was trying to make sure they had sufficient oxygen tanks, because what happens when the electricity's out and they can't run the oxygen concentrator? The company that normally would deliver oxygen tanks to their home has declined to make the visits to the Navajo Nation during this crisis. That means that Jay has to drive 175 miles one direction to pick up a supply of oxygen tanks for her mother. So that's a round trip distance of 350 miles. And then you add in the cost of gas and things like that. So that makes it extremely difficult to get even the basic things that people need. You know, FEMA delivered supplies to Tuba City in March. They built an alternate care site in Chinle. But one of the FEMA officials told Steve Holvey, one of the pediatricians at Tuba City, that no one was coming back. And on a regional call, Steve made the comment that was refreshing in its honesty, but how desperate does that make people feel when they're trying to deliver life-sustaining care to a community? One of the ways that we've tried to address the problem regionally is we've set up some regional calls. So some of you may know Mark Carroll. He was a physician at Tuba City for many years and currently is the CMO of one of the Access or Medicaid plans here in Arizona. And Mark was a little reluctant to be a convener, and I have to admit I nudged him because we desperately needed a neutral convener to bring people together. Because sometimes if the hospitals bring people together, they suck up all the oxygen. As a primary care person, I can say that. But we also needed somebody with the relationships on Navajo Nation, Hopi Nation, in the community health centers all across Arizona to bring people together. And that's been a great way to share resources. So Canyonlands is a community health center based in Page, and Lake Powell Medical Center. They receive a lot of patients from Navajo Nation. They've been able to participate in these calls along with others so that we can share resources, share masks, share gowns, and Flagstaff Medical Center helped set up a roster of nursing staff. It's not been a complete solution to the problem, but it's a way for all of us in Northern Arizona to help address it. There's also some more informal channels. So people in the public health nursing department at Kayenta reached out to me with some specific needs regarding thermometers, bleach, and masks. And I was able to source some bleach for the public health nurses. So sometimes we just have to be able to phone a friend. And I think that's critical in this time.
And I just have one more question I wanted to ask you about, and it's something that you alluded to about the transfer of patients who are critically ill. Can you just go into a little bit more about the complexities that may be happening? I have a little bit of experience. I've spent some time out in Tuba City as a resident in emergency medicine. And, we were taking care of an individual who was suffering from a heart attack, and we had to call an airplane to fly him down there to Phoenix. But just thinking about the volume of individuals that may need that higher level of care. Can you share some thoughts about that?
Yeah, thank you. Patient transportation is the norm in these communities. So I know when I worked in Kayenta, we didn't have an inpatient facility. So if there was anybody who needed to be hospitalized, and maybe it was for something relatively simple like urosepsis or a cellulitis, we would send them by ground, most commonly to Tuba City or Chinle, depending on bed availability. Because you always have to find a receiving doc for your patient. That's part of the work when you're in these rural environments, is finding somebody who will accept your patient. So ground transport is the norm. And if there's patients that need a higher level of care, they're often sent by fixed wing. So the reason that fixed wing is moved, particularly if somebody is intubated, is that you've got greater ability to move on the plane and manage the patient. Sometimes folks ask about helicopters, and helicopters are often used in trauma cases. So you can land in a field and do a scoop and run, or what we often did was hot load folks in our parking lot. So somebody might come from a trauma scene with a ground ambulance, meet the helicopter in the parking lot, and then we would load them from the ambulance to the helicopter, and then they'd be on their way. And we would do that because the staff in the helicopter could then go to whatever hospital was closest, and they would have to receive the patient. We didn't get into the complexities of having to find a receiving physician. So right now on Navajo Nation, the challenge has been having crews that are willing to take COVID-19 positive patients. So there have been some transport companies that have declined to transport patients. There's a number of air ambulance companies. I can think of Eagle Air, Guardian, AeroCare, and many of them maintain fixed wings across the Navajo Nation and just fly to wherever there's a transport needed. And right now, the volume has been able to to be absorbed by receiving communities. So, for example, when Tuba City is intubating and flying out 3 patients a day, where are they going? Typically, they're going to Flagstaff or to Phoenix. If they go to Lake Powell Medical Center, they're often flown to St. George up in Utah or Salt Lake City, sometimes Las Vegas. Sorry, I was blanking on the name. And then on the east, in the east, oftentimes they'll go to Albuquerque. And fortunately, these hospitals have been able to absorb a number of these patients. I know that for Arizona, Flagstaff Medical Center is feeling the burden of cases probably greater than some of our colleagues in the South. They have capacity for about 35 intubated patients. They've expanded their ability to ventilate patients, put in more negative pressure rooms, and basically created COVID units. You know, they've kept their total census to about 50 to 75% of normal, so that they've got the capacity to handle the COVID-19 patients. So in sum, that means that critically ill patients are flown hundreds of miles away from home, and they're in situations where they often suffer and may even die alone.
And I have a follow-up question that I want to get to you at a later point related to that very last comment that you made. So we'll bring that up in our next round of questions. But I want to transition to you, Dr. Ignace. So Lyle, I've known you for a while, and one of the things you always talked to me about was the complexity of Native American communities, and that you know, some communities are on reservations, whereas others are, you know, as a part of major metropolitan areas. And so you work at a community health center within a metropolitan area. And can you talk about some of the issues that Native Americans may be experiencing in urban communities? You're muted, Lyle.
Sorry, unmuted. Thank you. Thank you, Dr. Landry. So, you know, just to give a little background to myself, I'm Coeur d'Alene from Idaho. Born and raised here in Wisconsin. So to kind of give some context to urban Indian health, if you could move to the next slide. So the Gerald Ignace was established in 1999 as a 501c3 Title V Urban Indian Health Center. As a nonprofit, we reside on the south side of Milwaukee, and as a FQHC center, we certainly provide services to a tremendous population, not only to the Native community, but also for the general public as a whole. So we do service 8 counties that are adjacent to Milwaukee County, and we have a user population of about 16,000 Native clients. So and 44% of those reside in the zip codes adjacent to our location. So just to give some background, if you could go to the next slide. So urban Indian health organizations were established in 1976. And as time has moved, people have you know, migrated from reservations to the urban and suburban areas. And with that came a great need for healthcare. And, you know, health issues that were related to reservations, certainly that had followed Native families and established communities throughout the entire country. And so there was a great need for these health centers to start developing. And if you could go to the next slide. So as of right now, you could see the distribution of urban Indian health organizations throughout the entire United States. There's currently 41 United Urban Indian Health Centers in 22 states. And so in Wisconsin, you can see our location there. And so it's important to kind of get the sense of location and in relation to health centers. So if you could turn to the next slide. So it's important to know that, you know, these urban Indian health centers certainly provide a tremendous amount of service. Obviously, the primary health care aspect, diabetes care, chronic care, women's health, behavioral health, certainly traditional healing and medicine. That is an aspect of urban health, as well as social and community services. So it's important that these centers all have the capacity to be able to provide these types of services. So, you know, we know all of the health disparities that impact natives, not just on reservations, but also in the urban settings. So, you know, natives are 3 times more likely than the general population to live in poverty, to be uninsured, to have diabetes, hepatitis C. You know, certainly 2 times more likely to have heart disease, live in multifamily rental homes, multi-generational living. Certainly a lot more upper respiratory, COPD, asthma, and certainly a tremendous amount of smoking rates that occur. So, you know, these are certainly aspects that we have to manage and mitigate on a regular basis. So the issues, you know, the dealing with multi-generational trauma, as well as health and social economic disparities, certainly play a huge impact on Native health, and certainly during this crisis couldn't be even more evident as it is right now. So we deal with a lot of different health issues, social issues, and now we're definitely impacted by and the issues are more exponentially highlighted because of this crisis. So,
So thank you, Lyle. So one of the conversations that we were having around this is that this coronavirus is just exacerbating disparities that were already prevalent in the community, which I think you highlighted well. However, patients still need to receive care, and unfortunately, a lot of you know, primary care clinics have been closed or canceled. Day surgeries have been postponed, and other typical interactions that would happen with the healthcare have been delayed, and we don't know when those are going to be reopened. So can you talk about how your community health center has adjusted to COVID? Are you transitioning to virtual visits? And overall, what do you think the impact is going to be on those needed primary care visits that unfortunately aren't happening?
sure. So it's kind of interesting how you bring this up, because just like the entire country and all the other health centers throughout the country, whether it's urban or for the general public, the impact couldn't have been more harder on some of these urban Indian health centers, certainly because the capacity for us to deliver care. A survey recently came out from the National Council of Urban Indian Health, and found out that almost 50% of the urban Indian health centers did not have the capacity to meet even the medical service delivery, nor did they have the triage capacity, or almost 20% didn't even have telehealth equipment. So having to deal with some of these restrictions and limitations right off the bat made it almost impossible to deliver the healthcare needed. In fact, almost immediately, 3 urban Indian health centers had to close their doors. That was early on. They've been, since then, have gotten a lot of tremendous support and effort and equipment to reopen and provide services, but such a huge limitation. And actually only 2 urban Indian health centers had the ability to provide testing immediately. So, you know, given that as a starting block for a lot of the urban Indian health centers, there have been tremendous gains being made in order to help those needs. And telehealth is certainly that main approach. We're certainly no different, but the issues that will come down will be the chronic care management, preventative care, ortho elective procedures, even chronic pain management. These are all going to be huge issues, and some of the early indications are that because of our reduced encounters, that health centers they've lost at least 50% of their revenue that they're able to generate on a monthly basis, and I suspect that will continue to go down. But telehealth, I think, is going to be probably the mainstay for us right now. It certainly helps us provide care, although there are certainly limitations to that, given our population has limited access to internet, certainly laptops. Having a face-to-face interaction is difficult. People may not have smartphones, and if they do, they operate on a month-to-month budget plans. And, some of our clients have just flip phones. And so barriers, obstacles, we still try to reach out as much as possible. So tremendous issues, barriers, but we just keep trying to contact and interact with our clients as best as we possibly can.
And so it's interesting that you bring up the technology that's available to the patients that you're caring for, and we know that access to internet, broadband internet, computers, all of these things are going to be increasing the complexity of care that's delivered, especially when patients just don't have access to those resources. Can you talk about some of the other needs that your patients may have that we're overlooking because we're thinking about sort of these novel drugs that may be coming into a place, or the focus may be on elsewhere, like testing or PPE for those in the community health centers and in the hospitals?
Yeah, so, some of the issues that may not necessarily be talked about, we talk about the lack of supply or capacity to test. We were one of those health centers that had that ability up front, and so we've been testing since about March 12th. But looking at the context of natives and transitioning to urban settings, these urban Indian health organizations not only provide medical, but they also provide a cultural aspect and allow that connection to each other's native roots. And so a lot of these organizations have cultural programs, they have elder programs, youth programs, and so those are important aspects to offer. But probably one of the bigger things is housing stability. That is going to be an issue. Employment placement, workforce development. Some of our organizations have programs that have implemented, trained, and developed for our Native communities, and so that's going to be impacted tremendously. Given the economic situation, people who maybe have had a job, maybe it's an hourly job, maybe it's entry-level jobs, but these are issues. They may have been some of the last to be hired, but certainly first to be laid off or furloughed. And so that's an ongoing issue, generating income for families. Food security, with limited income, food security, and how that relates to the health and wellness of not only themselves, but certainly if they have chronic care issues such as diabetes, hypertension, hyperlipidemia, making food choices. Obviously, these are going to be huge aspects. And probably one of the other aspects, I know it gets into the headlines, but for natives, I think the mental health aspect. This is going to be a pretty dramatic issue for the Native communities in urban settings. So certainly for Native population, the silent pandemic of behavior and mental health trauma has long impacted our communities even before this crisis. And, you know, more recently, I would say in the last 5 years, organizations like ourselves and other federal tribal areas have really made inroads into the ability to not only engage the community, but really engage in the ability to interact with our native population in ways that we hadn't before. And so this crisis, you know, with the isolation and certainly mental health issues of depression, anxiety, all of this is really going to impact. And so for us to have that ability for telehealth is going to make a huge difference, at least right now in the short game, and hopefully long term, this isn't going to be a sad moment in providing mental health care for our community. So it's going to be difficult, and I think we're just scratching the surface when it comes to mental health in the Native community.
Thank you for bringing that up, Lyle. And I have a couple questions that I'd love to ask you around the mental health issues that we can refer back to later on. But I want to switch to you, Patrick. So can you talk about how you've experienced COVID, specifically you coming from two different worlds? You're Pueblo and Navajo from northern New Mexico, but you practice in an urban community. Can you tell me what you are hearing from your friends and your family and how they're dealing with COVID? And I'm sure some of the comments that you're going to make are going to echo what Lyle had already said.
Thank you, Alan. Thank you, Joan, for inviting me to be here today. Yeah, I'm Dr. Patrick Linson. I grew up just outside of Santa Fe on a dirt road. I'm the youngest of 9 children. Just to put this in context, I'm one of the few to graduate high school. I'm the only one to go on to college. I lived in a multi-generational home with my grandparents, my cousins. I have 60 odd nephews and nieces, many of which lived with me when I was in a young age. Growing up in rural New Mexico, much of this rings true to me today. I have most of my family still in New Mexico, extended family, my mom. And so a lot of good friends. And so this has been really hard for the last few months, watching what's happening, watching the numbers grow. And as a physician, you know, obviously feeling that we want to help in ways in which we can. You know, growing up, there were many times where we didn't have a car and just trying to get around. Oftentimes when you did, it was oftentimes in the back of a pickup truck. And when you had to do and even get food, when you have little money, it's hard to store up food for 2 or 3 weeks if you have very little access to money. And even going to a grocery store could be challenging. If you could put up my first slide. So just as a Navajo person and a Pueblo person, just in general, in northern New Mexico, there's high rates of poverty. 40% on the Navajo reservation live in poverty. 42% of people are unemployed. Part of it is of lack of resources, infrastructure. When you talk about, you know, getting food, when you have very little access to income, it makes it challenging in that regard. Running water, we're talking about having to wash your hands to do it for 20 seconds. Well, it's hard when you don't have running water, and 40% of our nation lack running water. 30% lack access to clean water. Another 10% lack electricity. It wasn't uncommon for our neighbors to not have water or electricity, and we found ways to work around it, but it makes it challenging when you're in a shutdown. Infrastructure, like myself, 78% of the roads are not paved on Navajo Nation. Healthcare, as we'll talk about, and as Donald will spend more time talking about, is fragmented and underfunded. You know, about a third of what Indian Health Service per person sees compared to Medicare and equivalent populations. And so trying to make do with what you have, and having spent 4 years working at an urban Indian health center, opened my eyes to many of the needs, not just both in rural New Mexico and on reservations, but actually for Indian people living in urban communities, as Lyle just outlined. Life expectancy on the reservation is already 72 years compared to 77% for non-natives. Revenue right now, we're still waiting for some of this money to come in from the government. But until that time, our nation's been doing its best to try to provide the resources that are needed. But you have to understand, a good percentage of the resources coming into Navajo Nation come in from mining, which is closed, the taxes which aren't coming in, the casino, which is closed. And as it is, mining was already a decreasing revenue stream. So far less revenue coming in to take care of the people that were already challenging to treat as it was. Lack of transportation. There's very little or no public transportation on the reservation. And I was poignantly outlined by Ann, this is a very large reservation with people having to travel distances to do simple things, and having a lack of transportation or having shutdowns. We're talking about weekend-long shutdowns, and what it already means to do what you need to do just for your basic survival, much less in a time of crisis. 60% of people don't have telephones or telephone access. So if we're talking about at some point doing contract tracing, how are you going to do that short of driving to somebody's home when it's already hard to get there, much less just to be able to call and talk to somebody about who they've been in contact with? And you're talking about multiple generations living in a single home, each of which can have access to a variety of different people. You can see where this is going to be a challenge. My first exposure to the lack of Native physicians, as we all know, was working in an urban Indian health center. And to my surprise, and this is now going back 30 years, at that time, there were fewer than 1,000 Native doctors in the country. And you're talking about 700 tribes with 1,000 Native doctors. It doesn't take much to do the math to see the limited number of doctors we have in our community. We're very fortunate for Indian Health Service. We're very fortunate for the number of doctors who have contributed to our health, but it means it's tough for continuity of care when we have doctors coming in and coming out of the system, and to be able to provide that type of healthcare that's needed. 70% of our elders do not get routine, regular medical care. So if you already have a patient that's not doing well, we already have a population that has overrepresentation of diabetes, obesity, asthma, and now on top of that, not regular health care. And in the setting of a crisis, we can see how this could be so much more challenging. So in talking to my friends, talking to my family, talking to my colleagues, seeing these challenges is clearly something we're aware of, and trying to do what we can to address them in ways in which we can, and we'll talk about more.
Thank you for that. So, Patrick, in our prep call for this conversation, you shared with me a story that I thought was really interesting, and it gets to the heart of an issue that a lot of us are facing as we try and address the COVID-19 crisis firsthand. And so can you tell me can you share with the audience, I guess, a little bit about your parking lot interaction in order to support a community health center, and just tell people what was actually happening in order in this interaction.
Sure, Alden. So many of you guys know Dan Kalak. Dan is the Chief Medical Officer for Indian Health Council. Indian Health Council services 9 of the reservations here in San Diego County. People don't think of San Diego as being an Indian hub, but there's 18 reservations in San Diego County. There's more Indian reservations in San Diego County than the rest of the country. I've known Dan for 30 years. Dan was my replacement at the Urban Indian Health Center, the American Indian Health Center in San Diego. When I left, I had been running a number of HIV and AIDS programs there. Well, I now work for a large institution. There's 15,000 employees with Scripps Clinic Medical Group and Scripps Health here in San Diego. And we were going through troubles finding PPE for our staff, for our patients. As a physician, I'm a cancer specialist. I treat brain, lung, and prostate cancers with radiation. I was concerned for my patients getting adequate, even wearing masks. And we're having a shortage here. Talking with my friend Dan Kalak, and asking him what his concerns were. Well, not surprisingly, they're having troubles there too. Like Lyle, they were able to get testing equipment early, but they didn't have the appropriate PPE for the colleagues and the people that were going to be actually doing the testing and the frontline folks. And so in talking to him, he had heard, and we had talked about my kids. My son's been making face shields. You makes them out of our house. And my daughter's been making masks. And for the last 6 weeks, she's been making masks, over 300, my son over 100 face shields. And he said he needed some face shields and some that fit. Sometimes Native people are a little different in sizes. When they send small, medium, and large, sometimes those aren't necessarily in the Indian sizes. In any event, so I met him. It's funny, I saw him in Alden, but last weekend we met in the parking lot and sharing some of our stories of what's going on and just catching up. And so I was able to pass along some PPE to him. And this isn't just, we're looking at a large healthcare organization that has buying power and has resources and having trouble getting PPE. We know that, and we're seeing that across the nation, PPE is getting difficult for all our folks. If you could put to the next slide. So my background, and going back, like I say now, about 30 years, was working at the San Diego American Indian Health Center. It's a large urban Native American community. Lyle had pointed it out on one of his slides. And at this community in the center, we treat high rates of people had unemployment, poverty, drug, alcohol abuse, HIV, and AIDS. My first pandemic was 30 years ago, dealing with HIV and AIDS. I spent 4 years working at this clinic in HIV and AIDS related programs before I went to medical school. And it opened my eyes to what happens in a pandemic when you already have a population that has disadvantages. In that time working there and coming across and meeting many good patients and doctors and healthcare professionals, and it kind of gave me a basis for understanding what's happening now. And I have to say, it brings back a lot of pleasant, but also bad memories of knowing that we've got some serious hurdles ahead of us. We already have challenges at baseline, and this is certainly going to stretch the resources and make it more challenging to do the types of things that we need to do. But Dan, the story that comes up with Dan comes all the way back this 30 years. And Dan helped us when I was, with the help of Joan, this now 30 years ago, we started a program as a first-year medical student. And one of the programs is to basically create awareness about the need for Native American physicians. 4 Directions Summer Research Program. We started as a first year. My colleagues Brent Hale and Sean Franklin put together this program. And fortunately, now 25 years later, with the help of Dr. Tom Sequist, the program's still running. But to address at least the need for physicians, we're kind of start at square one. Joan recognized this problem a long time ago, not just in Native populations, but minority populations in general. And it's not just healthcare professionals. You got to start, in elementary school, middle school, to get the kids to build that pipeline to move things forward. I was fortunate enough to be a medical school student to bring Dan. He was one of our first 4 Directions students, to then see Dan go on to become my program director for 4 Directions, to then see Dan go to become the first doctor in his tribe, the first person in his tribe to become a physician. He now is the chief medical officer for his tribe. He's still looking for his replacement. He wants to find the person that will someday replace him in the clinic, knowing that he may have another 10, 20 years, but he's going to need to find a doctor to replace him. But in any event, Alden, thank you for allowing me to share that story.
Thank you for sharing it. And just one last question for you, Dr. Linson. So, we know that health disparities issues have existed for eons. And, now that we're in this space of COVID, we know that these health disparities are now being exacerbated. Can you just talk a little bit more about what's happening with the exacerbation of these health disparities, whether it's access, whether it's the burden of disease that populations are facing, or whatever thoughts you may have on this issue?
So first, as an oncologist, cancer also in different ways that adversely affects minority populations. We see higher rates of certain cancers in our populations compared to the dominant culture. And as a result, in taking care of a patient with cancer and as a subspecialist, it's already a challenge. And when it comes to COVID-19, we have to remind our patients that oftentimes the cancer is more deadly than COVID-19. We need to continue our treatment. And when you're talking about cancer care and radiation, generally you're talking about 6, 7, 8 weeks of daily treatments, Monday through Friday. You're talking about patients that sometimes have to travel an hour or two each day to get to their treatment. And these are patients who are already struggling to try to find a way to get their cancer treated when they might not be able to work, when they're already struggling to make ends meet. And now you throw this extra layer of complexity. So we're doing our best in that regard to take care of our cancer patients. And I know this holds true for not just cancer, but a lot of the different specialties and non-subspecialties, as Dawn, I'm sure, is going to talk about more in a moment. But if you come back to that first slide again, healthcare disparities are very high in our communities. And while this points out the Navajo Nation, we can point out similar and like disparities across Indian country. And so it's going to take a challenge. It's going to take a concerted effort. It's going to take a lot of people coming together to try to find good solutions. And we're a very resilient people. We found ways to overcome pandemics before. Smallpox, not too long ago, H1N1. Our inner city communities were ravaged by HIV and AIDS. San Diego has a large Indian population for a number of reasons. One, there's 18 reservations in the county. Our urban population also sees a large number of people coming from the military. There's a large number of military bases in San Diego. And as you know, natives serve in a higher representation across the country compared to other races in the military, and many of which come to San Diego stay. But it was also a place where Native people were relocated. And the idea is in the 60s, 70s, we can get rid of the Native problem by moving natives to the cities. And that didn't necessarily work. You moved a large uneducated population to the cities, which became its own equivalent of a barrio, and with limited resources, limited employment opportunities. And so we still have those issues to reconcile with, both in rural as well as urban communities, which is going to take a challenge moving forward.
Thank you, Dr. Linson. Dr. Warne, I want to turn to you and talk about this from a public health perspective. A lot of our conversation has really been focused on the clinical care of patients. Can you talk about how tribes and how communities are addressing COVID-19 from a public health standpoint?
Absolutely. Well, first, hello, thank you, and welcome to all my friends and colleagues who are on this call. I really appreciate the opportunity to be a part of this important discussion, and also thank Dr. Reed and Dr. Landry and the rest of the team at Harvard Medical School, including the American Indian perspective on these issues. And what I'll talk about is the public health considerations that Dr. Landry posed, but also looking at some of the national policy considerations in terms of how national policies and underfunding of the Indian health system over time has led us to have much more risk and susceptibility to things like a pandemic. So just very briefly, I am director of what's called the Indians into Medicine, or INMED program, as well as director of our public health program at University of North Dakota School of Medicine and Health Sciences, where I also serve as the Associate Dean for Diversity, Equity, and Inclusion. So if we could go to the first slide, I just wanted to briefly mention some American Indian demographics. And of course, we have a census coming up, which is another area where the pandemic will have an impact, is whether or not we have adequate participation in the census. But according to the 2010 census, our last full one, there were over 3 million people who identified as American Indian only in that census. But when we look at the American Indian and other races or ethnicities, it's actually over 5 million in that census. So we know the numbers are going to be larger, but again, with the pandemic, we don't know what the exact outcome will be. And I really do appreciate Dr. Ignace and Dr. And other discussions related to the urban population, because I think there's kind of an assumption that most of our population lives in reservations, but actually the vast majority of American Indians live in cities. So, as Dr. Linson was mentioning, there's a lot of people who live in San Diego and other cities, but also here in the Northern Plains, we have a lot of people who live both in reservation communities and in cities. So we have to recognize when we're dealing with American Indian challenges related to public health that we have to have different strategies. We have to have a strategy to address the reservation-based populations, which particularly at Navajo and certainly here in the Northern Plains, they tend to be very rural, very remote, and very impoverished, and really lacking in infrastructure. So when we think about the people who use Indian Health Service, there's about 2 million people who are in what's called the user population and have an active chart within the IHS or tribal or urban programs within the last 3 years. So we do serve a lot of American Indians through Indian Health Service and related programs, but not all American Indians are served by IHS. So a lot of people go to private sector facilities. That even complicates further data collection because not everyone is in the exact same data set. In terms of funding for Indian Health Service, it's actually about $5 billion a year for appropriations. Of course, with the CARES Act, there's an additional $1 billion that goes to Indian Health Service. So I'm hoping that we can actually find a silver lining within the terrible pandemic that we're dealing with in terms of recognizing the public health needs and the lack of infrastructure and how that puts our people at even greater risk for poor health outcomes. It's also important to recognize we have a lot of tribes, over 570 federally recognized American Indian and Alaska Native tribes. And when we think about that number, it's a lot of tribes. It's essentially nations within the nation. They're all sovereign nations. So one thing to keep in mind, of the 574 actually, over 200 are located in Alaska and over 100 are located in California. So the majority are just in those two states. And many of those communities are very small in terms of population and land base, whereas when we're talking about Navajo Nation or here in the Northern Plains, they have, we have less numbers of tribes totally, but the tribes are much bigger in terms of population base and land base. So please go to the next slide. I also wanted to show the distribution of our population across the country. And this is from US Census data. And you can see if we look at the concentration of indigenous population by county, you can see the vast majority of American Indians are in the western half of the country. And there are reasons for this. So the main reason, of course, is that colonization started in the East. So as a result of colonization, many of the tribal nations in the East are no longer there, unfortunately. And it's kind of outside the scope of this particular discussion, but there is a long history, unfortunately, of genocide and destruction of the indigenous peoples, even purposeful spread of disease. So some of our earliest epidemics, including things like smallpox, there's evidence of intentional spread of things like smallpox to the Northeastern tribes. I'm sure people have heard of Amherst, Massachusetts, and Amherst College. That's named after Lord Jeffrey Amherst, and he was a colonial governor who actually ordered the distribution of blankets from a smallpox hospital with the purpose of killing the tribal people in the Northeast. So that's why we have so few American Indians left in that region of the country. So when we talk about pandemics and issues related to infectious disease, we do have to recognize there's a longer history here in the US with indigenous peoples having to deal with these horrible outcomes. And then in the Southeast, many of the tribes were removed from their homelands. In 1830, there was the Indian Removal Act that actually relocated many of the tribes from their traditional homelands to what is now Oklahoma. So that's why the map looks this way. And if colonization had occurred in the West, the map would be reversed, essentially. So one issue from a policy perspective to keep in mind is that we have about 15 states that do not have federally recognized tribes within them. So from a political perspective, what that means is that 15 states, or 30% of the Senate, has no tribes in their jurisdictions. So that puts us at a political disadvantage. If we don't have representation across all of those states, we don't have representation in Congress, and that's where laws are made and that's where appropriations are made. So we have a long-standing challenge politically in terms of underfunding, and that has a direct impact on worsening risk for bad outcomes during a pandemic, and even in normal times we have worse health outcomes. Go to the next slide, please. So when we have to think about, why is there an Indian Health Service? And I think one thing that's not well understood is that American Indians and Alaska Natives are the only racial or ethnic population that's actually born with a legal right to health services. And there's reasons why we have a legal right to health services, not just medical care, but even public health. And that goes even all the way back to the US Constitution. The Commerce Clause, which is Article 1, Section 8, states that Congress shall regulate commerce with the foreign nations and the Indian tribes. So we were put on par with foreign nations as Indian tribes. So within federal Indian law, that's kind of seen as the basis for tribal sovereignty. Of course, as tribal nations, we've considered ourselves sovereign long before there was a US Constitution. But there was that terrible interaction, unfortunately, with tribal nations and US government historically that has led to intergenerational disparities. In addition to Constitution and other laws, we also have treaties. So we have hundreds of treaties between the tribal nations and the federal government. And this is just one example. This is the Potawatomi Nation Treaty from 1846. And I know it's in very fine print, but at the bottom it says the United States giving at the same time promise of all proper care and protection. Promise of all proper care and protection. And that's common language in many of our treaties. And treaties are the highest order of law in the land. There's even a treaty clause in the US Constitution that states that. So a treaty is essentially a contract between the federal government and the tribal nation. And there's, again, hundreds of those treaties. And by not fully investing in our needs as American Indians in terms of health, we are actually seeing a breach of contract between the federal government and the tribal nations. And as a result of that, we're seeing worse outcomes in many of our populations. Go ahead and go to the next slide. I think it's also important to understand that there are several health systems within the Indian health system. So we know Indian Health Services, IHS, that was funding for that was actually established back in the 1920s under the Snyder Act. And the Snyder Act allows Congress, or gives authorization for Congress to spend funding on American Indian health needs from time to time. So recurring funding goes all the way back to the Snyder Act in the 1920s. In the 1970s, we did see a lot of changes. So the tribal programs, the T of the ITU system, were established under the Indian Self-Determination and Education Assistance Act. And the law is called Public Law 93-638. And the reason we have a mixture in our reservation communities of IHS programs and tribal programs is because of this law. The tribes have the right to take over the management of health systems from the federal government. So in Indian country, the term 638 has actually become a verb. You know, we're going to 638 the clinic or 638 the hospital. That basically means to take it over. So how does that have an implication in terms of the pandemic? Well, within, for example, the money that comes into IHS and certainly for COVID response, it's relatively easy for IHS to work within the federally managed programs, but there's an extra step in terms of getting resources to the tribal programs and how do we amend those contracts and compacts to get the dollars there. The other consideration is that IHS is doing a very, very good job of tracking data in terms of the numbers of people being tested for COVID-19 and the numbers of positive cases. The challenge is the tribal data and the urban Indian health data is optional for them to submit those data to Indian Health Service. So again, our system is much more complex than most other health systems. And data management is already difficult enough, but we have even more layers due to this historical policy consideration. And as was mentioned by Dr. Linson and Dr. Ignace, the urban Indian health centers were established in the 1970s as well under the Indian Healthcare Improvement Act. So go to the next slide. So one of our big challenges, and this has been an ongoing problem forever, essentially since we've had American Indian health programming, is severe underfunding of the IHS. So these data are about 5 years old, but we haven't seen significant changes in the patterns of appropriations. So for Medicare, for example, they're funded at about $12,000 per person per year on average. Veterans Administration, nearly $9,000 per qualifying veteran per year. Medicaid, nearly $6,000 per person per year. If you're a federal employee, under federal employee health benefits, $5,400 per year, and IHS for medical care, about $3,100 per year. So one thing to keep in mind is that Medicare and Medicaid and federal employee health benefits are insurance programs. IHS and VA are not insurance programs, they're actually direct providers of care. So it gets a little bit complex trying to compare the actual amount of money that's spent per federal health system. But we know that IHS is terribly underfunded relative to the rest of those systems. And this is the mechanism by which the federal government is supposed to live up to its treaty obligations to provide health services, not just medical care, but also public health. Indian Health Service is a part of the US Public Health Service. And unfortunately, we spend relatively little on public health because our costs are so great managing chronic disease, like was mentioned, higher rates of cardiovascular disease, higher rates of diabetes, higher rates of cancer. So what winds up getting neglected is public health. And because of this long-standing policy history and lack of adequate investment and lack, quite honestly, of the federal government living up to its trust responsibility to provide these services, we have a population at tremendous risk for bad outcomes because our public health infrastructure is not at the level it needs to be to respond to this type of a challenge. So go to the next slide. This is my last slide in the file here. But just thinking of this, how does this apply in very practical ways? So it's been described a lot as the 3 T's in the response, right? Testing, contact tracing, and treatment. So in terms of testing, I've been working a lot with the Great Plains Tribal Chairman's Health Board to address some of the challenges here in the Great Plains area. So that's North Dakota, South Dakota, Nebraska, and Iowa. And there are challenges in getting adequate testing into the communities. In some cases, they've been able to distribute the hardware that's needed in terms of the testing instruments, but then not enough reagents to actually do the testing. And I think the numbers have increased, but when it first started out, they had all this brand new equipment, but only reagents enough for 700 people. And that's serving well over 100,000 American Indians in the Indian health system. Having enough reagents to only test 700 is clearly inadequate. But again, much of that is a result of longstanding lack of infrastructure. Then of course we need contact tracing, and that's relatively time intensive because anytime someone tests positive, you need to know who they've been in contact with over the previous 2 weeks. So it can be done by telephone, but we don't have a workforce of public health professionals just kind of sitting around waiting for something to do. So it's also a workforce issue in terms of even something as simple as training for contact tracing and ensuring that we're compliant with personal health information and data management. And then finally, treatment. And I think Dr. Linson, Ignace, and Newland all really address this very well in terms of lack of local access. Here in the Northern Plains, on our reservations, we do have a few hospitals, but none has a intensive care unit and intensivists that can actually respond to some of the higher level treatment needs. So we do have to look at things like telemedicine, of course, but telemedicine alone will not solve the intensive care needs. We have to be able to refer patients to the private sector as well. So again, just longstanding lack of infrastructure, in many cases, less access to personal protective equipment has created some challenges. So just very briefly what we're doing about it. Here at University of North Dakota, we do have MPH, Master Public Health students and other graduate students who are now working with the state of North Dakota to do contact tracing. So of all the states, North Dakota actually has the highest concentration of contact tracers of any state now, a lot of it because of what we're doing here as well as North Dakota State University. Also looking at how we refer that purchased and referred care to the private sector. Because IHS is terribly underfunded, we don't always have adequate payment systems when people are referred to the private sector, and clearly we need strong coordination for referrals. And then finally, strike teams. We have high-risk populations. We think of nursing homes and jails and congregate housing, but in many of our communities, we have multiple generations living in the same home, overcrowded housing like Dr. Linson was describing as well. So we need to be able to test everyone simultaneously. So that's the purpose of the strike teams, to have higher levels of training. And then also we have a Indigenous Health Master Public Health program that's available online, and Indigenous Health PhD that's just getting started and we're hoping to add to the workforce and infrastructure through those programs. And I'll go ahead and end it there. Thank you.
So I just want to, just being cognizant of time, I'll start with a question for you, Don, and then I want to try and jump in and try and answer some of the other questions in the Q&A session. So Don, if you could just quickly tell me what tribes and what tribes are doing when it comes to potentially engaging in research opportunities related to COVID. There's some discussions about drugs that are becoming available as interventions for COVID-19. And do you know if the IHS system is going to be open to those trials or if they are interested in participating? And then also maybe juxtapose that to what are Native Americans interested in being a part of these clinical trials given their history and interactions with the healthcare system?
So I can speak to what's happening here in the Northern Plains. Again, there's a lot of diversity across Indian country. So there might be some areas where tribes are participating, but what I'm seeing is that there's such a tremendous need for initial response, just from a public health perspective, that I haven't seen any proposals for participating in clinical trials, for example, related to COVID. There's so much concern just over the initial response and protecting the populations. But you are correct that there's a longstanding history in which tribes feel like they've been used for data collection, but not necessarily benefiting from the outcomes of research. So we do have hindrances in terms of promoting appropriate research in our communities. And of course, again, each tribe and each region is different, but I think it's important to look at building the research capacity within Indian country so we can start moving the research agenda forward in a culturally relevant manner.
Thank you. And so I want to open it up to all the panelists for questions now. And so I guess the first question I'll go to will be to you, Patrick. So Patrick, can you talk about what is happening when it comes to the communication around COVID-19 and how the messages around social distancing and or physical distancing, the hand washing, you mentioned that earlier, but how some of these messages are reaching out into the communities. Oftentimes, as Don just mentioned, not everything is culturally sensitive. And so there may be some barriers in people receiving information based on the way that we're actually trying to deliver that information.
It's interesting because we had seen similar problems back in HIV and AIDS, and we found that targeted culturally sensitive material was much better received than something that was just created for the general population. And so there's one saving grace, I think, of social media is the ability for people to interconnect. And so we've seen actually really great stuff coming out, culturally sensitive material, talking about, sometimes it's not so much the individual that'll care about themselves, but if you talk about caring about your elders, that's the message you want to send. So people will do what they need to for their elders. If it means, social distancing or what we're calling physical distancing, and that in our communities, it's hard to social distance. We're a community that generally engages in a lot of activities together. So physical distancing means separating by 6 feet, where socially you could still socialize, but have to do it as a distance to protect your elders. And so I would say that we're seeing a lot of good resources coming out now, culturally sensitive, specific, and I think that's been very helpful.
Thank you. And Lyle, so there's a question or two about your community health center. And I guess one of the concerns is for community health centers, especially urban community health centers, has IHS been responsive into the needs that your community health center may be facing, specifically related to testing supplies, and then also related to personal protective equipment such as masks and gloves?
Sure. So yeah, absolutely. IHS has certainly been supportive. The funding allocations that have gone through the Indian Health Service also transpires to tribes as well as the urban programs. The amount certainly isn't as much as tribes or other federal agencies, but we do get a portion. So we're certainly thankful for that. In terms of testing and equipment, IHS certainly has been supportive in that regard as well, providing N95s, PPE equipment. They've been as responsive as they possibly can given all the bottlenecks. And one of the things, because of such a huge limitation in our capacity up front, we actually had to be creative and started developing a collaborative approach with our Wisconsin Primary Healthcare Association, along with the other FQHCs in Milwaukee, along with the health systems, city, local, and state health departments. We consolidated our resources and efforts to increase our capacity for testing. And so while we get help and assistance greatly needed from our federal IHS, we've also worked with all of our other community health centers in Milwaukee. And so we certainly have a lot of testing capacity right now. We've launched a citywide effort to increase testing for not only our active Native community, but also to the general public as a whole. So we're part of that greater effort in that collaborative approach.
Great, thank you. And Dr. Newland, towards the end of your presentation, you mentioned about how families are going to be separated because of the distance that patients have to go in order to receive care. And unfortunately, we know that patients who are put on ventilators have anywhere between 78 to 80% mortality rates. Can you talk about what you have seen that's been done to have conversations about end-of-life care, goals of care for these patients who are critically ill, and how those conversations may be happening with families, over long distances?
Well, I can say in a Navajo context, it's important to have appropriate language to talk about death and to talk about the possibility of death without it appearing that you're wishing death on someone. And I think for individuals who have not worked in those communities, they may not have developed the language to have that conversation. And without revealing privileged conversations, I know that sometimes the conversations around withdrawing therapy have not gone smoothly. And at a time when people are already under tremendous strain, to feel like these conversations aren't handled with great sensitivity just increases the pain. And I'd like to emphasize that in small communities where you're so connected, where your layers of knowing and relating to each other are so deep, every loss is profoundly felt. And it's like a ripple through the whole community. And I know in Kayenta and Chilchimbito and Navajo Mountain, people have lost teachers, they've lost healthcare workers, they've lost grandparents, and the wound is very profound.
And so, Dr. Warne, I wanted to turn to you about this question. We're worried about how disparities may be exacerbated by this COVID-19. So can you talk about how Native American populations may be included or excluded when it comes to vaccines, treatments such as remdesivir, and other interventions that may potentially worsen the disparities if Native American communities aren't included early on?
Yeah, so thinking about this on a couple of fronts, there are disparities related to existing chronic diseases. We have highest rate of type 2 diabetes in the world, for example, and obviously we see worse outcomes when people have COVID-19 and diabetes, so that certainly worsens the disparities. Generally speaking, if someone doesn't have insurance and they're dependent on Indian Health Service, we don't always have access to the newest medications, whether it's for COVID-19 or even for chronic disease. The other issue that Dr. Linson had also mentioned is, what about cancer treatment and cancer screening? And we're seeing less screening as a result of the pandemic for cancer. But for American Indians, we also see the latest stage at diagnosis for cancer. So by delaying screening in our population, unfortunately, we probably will see worsening disparities over the next couple of years on all of those fronts.
Great. So in the interest of time, we're going to need to end soon. But just a question for all the panelists. Do you have any suggestions as far as resources for those looking for more information related to COVID specifically and its impact with Native American communities, how they could potentially support communities. So I'll go to you, Dawn, first, and then we'll go through the other panelists.
Yeah, I'd recommend looking at National Indian Health Board website, NIHB.org. They have a lot of resources for COVID-19 and areas to help.
Okay. Anyone else?
There's a Navajo Hopi Coalition that has a GoFundMe site, and I know that individual sites are taking donations. I'd be happy to send the links to anybody who's interested.
There's some specifics that are needed too that are outlined. So not everything's needed. So looking to those resources would be helpful for those folks that want to help.
Great.
Another resource may be the National Council of Urban Indian Health. They certainly have latest legislative approaches and items on their docket to address. So that would be another resource.
Great. And so what we can try and do for our website for the Office for Diversity, Inclusion, and Community Partnership is to compile a list of the resources that our speakers mentioned and have that list available for you all to review. And just to answer a question that has popped up a few times, the webinar will be archived and available on our website shortly. So if you're looking for information specifically about comments that our presenters have made, looking for some of the slides that they are sharing, all of that will be available on our website soon. With that, we are going to wrap up. I want to say thank you for our panelists. Thank you to Ann, Patrick, Don, and Lyle for sharing your expertise in this area and talking to us about Native American health. I want to say thank you to Ying and Pinar for putting together an excellent panel and helping us to troubleshoot all of the issues that we've may have had with the webinar. For the audience that is with us, I would love for you to help us and please in the answer the following poll questions. Pinar, if you can place that. Can you please address these two questions quickly? And then secondly, for those of you who are still with us, can you please be sure to put in the comment section or the question section other topics that you would like to see us discuss as we move forward. We're considering other equity and social justice webinars, both related to COVID-19 and then also other issues that may go beyond COVID-19. So please be sure to include those topics in the question and answer section, and we will go in from there. We do have another event that will be happening this afternoon. It is focused on medical students. We will have a discussion around applying to residency in the COVID era, which will be at 4 p.m. today, and registration is still open. And then also on Thursday, May 7th at 4 p.m., we will be hosting the 2020 Minority Health Policy Annual Meeting. It will be in webinar format, and you can register on our website there as well. Again, thank you to our panelists, thank you to the DICP staff, and thank you for Dr. Reed and Harvard Medical School for hosting this discussion. And with that, we wish you a happy and healthy afternoon. Take care.
Thanks. Thank you.